Thanks very much for the invitation to speak today. It's a real pleasure to be able to speak to you about public health, but also particularly mental health in the context of the pandemic. Just before I get to the substance of my talk, just to note a few declarations of interest, and in particular, that I'm speaking very much as an independent academic, not on behalf of any organization. So for those of you who are familiar with health, this picture will be well known, but it's a commonly used model that highlights the drivers of good public health and also many of the drivers of health inequalities as well. And what it draws attention to is actually healthcare services, and the NHS is only a very small part of the picture. Actually, many of the key things that determine our health are about our daily lives, our working conditions, education, living environments, and so forth. And one of the really nice and unique things about understanding society is it allows us to have information on these drivers of health, which many typical health data sets don't include. So within the pandemic itself, we've seen that while the UK has had an aspiration of having a world-beating test and trace system, which may or may not have actually been fulfilled, a league table that the UK is towards the top of, unfortunately, is in terms of COVID-related deaths. And what I'm going to suggest is actually one of the reasons for that is some of the factors that were happening before the pandemic, including some of the social policies in particular. And I'll go on to then suggest that actually the social policies, as we move out of the acute phase of the pandemic, will continue to be really important for public health and especially mental health. So before the pandemic, we were already experiencing a public health crisis. So unusually in historical terms, we'd seen a stalling of life expectancy. So historically, life expectancy had continually improved for many decades, except for around the time of the two world wars. But generally, there'd been pretty good improvements in life expectancy. And unlike many other countries, often with better life expectancy than the UK had, there was a stalling life expectancy. And actually, amongst some groups, probably even a fall in life expectancy. So there are potentially a number of explanations, including the role of social policies, and it's been argued that a lot of so-called austerity policies have played an important contribution, as well as potentially other kind of political challenges that were being experienced before the pandemic that meant that arguably some of the investment in public health services, but also NHS and social care and other key services was maybe a bit lacking. But actually trying to tease apart the effects of social policies on health is quite difficult, especially when we're trying to track things through to mortality type outcomes, the deaths. Whereas if we're looking at mental health, then often we're slightly more able to observe the impacts because the time lag between changes in social policies and mental health impacts is often shorter. So when we've tried to, so I'm going to give you a couple of examples of times we've tried to do that. So the first is there's been an important policy reform around the provision of income support targeted at lone parents. So as many of you will know, lone parents often have higher rates of poverty and also poorer health. And over a period of a few years, there was a stepwise reduction in automatic eligibility for income support. And the way that was implemented was based on the age of the youngest child. So it used to be the case that you would be automatically entitled to income support if you had a child under 16 years and you were a lone parent. That age limit then fell to 12 years, 10 years, 7 years, 5 years, and then 3 years. So that step nature of change allowed us to do an evaluation and actually try to understand the effect of the policy itself. So by using the rich longitudinal nature of understanding society data, and because there's such a large sample, we were able to define two different control groups compared to the group of people who were newly affected by the policy reform. So we can look at what happens to people who age into being affected by the policy reform and compare that to people who had already been affected and people who remained unaffected. And when we did that, we found that actually there was quite a noticeable adverse impact on mental health. So the negative numbers here indicated deterioration in mental health. And as you can see, we observed quite a consistent pattern of deteriorations in mental health, irrespective of which control group we compared to and which statistical model we used. And similar analyses have been done in relation to universal credit by colleagues in Liverpool. And we're currently in the process of working with them to update this analysis. So as universal credit was rolled out across the UK, initially focused on unemployed people, there was a deterioration in mental health, again seen as in the areas where universal credit was implemented compared to those where it hadn't yet been implemented. So much so that there was an estimate of over 20,000 people who would experience depression as a consequence, just amongst that unemployed group. So pre-pandemic, there was already a whole host of public health challenges where the role of social policies was particularly important. As we then experienced the pandemic, we had a lot of uncontrolled infection early on and quite a radical policy response that was needed because of the high levels of infection. Unfortunately, that then results in quite a large range of health impacts. So I apologize about the complex slide here. The main things to take away are probably that it is quite complex, the health impacts. So in the purple on the left, you can see some of the direct health consequences of COVID on health. But there's also a whole range of pathways that lead to indirect health harms as well. So, for example, through impact on education, transport, but also crucially, disruption to essential services like health services and disruption to the economy and the world of work. So as we think about that, it's probably no surprise that there was quite an adverse change in mental health during the pandemic. And we can see, so this is psychological distress as assessed through the GHQ caseness measure. So it indicates experiencing a common mental health problem. And you can see the proportion of people with that issue has really shot up during the pandemic. But it's been quite disproportionate amongst some groups, so especially young people, women, and some ethnic minority groups. In terms of think about access to healthcare, by working with the Understanding Society team, but also working across some of the other big longitudinal population-based studies, we've been working in response to the needs of policymakers to address key priority questions by bringing together a lot of these existing data sets. And here's an example of that, where we've looked at people's reported experience of healthcare disruption. And to give you a flavor of some of the findings, we've seen that actually experiences of healthcare disruption have been quite unequal. So, for example, amongst many ethnic minority groups, they've experienced greater levels of healthcare disruption than other groups, for example. Similarly, we've also been looking at issues related to vaccine hesitancy. So this has now become quite well known, but quite early in the pandemic, or at least early in the vaccination program, thanks to the timely data collection that the Understanding Society team did, we were able to look at what predicted vaccine hesitancy and identified that not only was ethnicity really important, but actually there was a lot of variation, a lot of heterogeneity across different ethnic minority groups. So it isn't the case that all ethnic minority groups had high levels of hesitancy, and that then led to trying to target public health interventions to encourage uptake amongst some particular communities. So as we're beginning to think about emerging from the acute phase of the pandemic, as has already been noted, there's been a lot of economic disruption, and a lot of the issues that the pandemic has thrown up are likely to cast a long shadow, including people's experiences of delays in life transitions. So, for example, delaying the entry into the labour market, delaying partnership formation, and so forth. And all of those things are likely to have quite long-term health consequences. Similarly, the high levels of COVID infection there's been are likely to lead to a substantial burden of long COVID, which might lead to longer-term disabilities. And the way we try and address some of these societal changes, and in particular the social policies used, are likely to have really important implications for public health, particularly mental health and health inequalities. So to try and inform and understand what some of the policy options might be, we're at the moment trying to develop a policy model. So many of you will have come across some, or at least heard of, some of the COVID policy modeling that's been done to predict levels of infection, hospitalization, and so forth. But actually trying to apply this approach to look at mental health has been less undertaken. But because we have the access to the Understanding Society resource, it becomes possible to try to do that. So we're trying to develop a policy model of different income and welfare policies and looking at what their implications might be for mental health and health inequalities. But to do that, we need to actually understand some of the causal effects that apply pretty well. So a key parameter here is understanding what's the role of income in income for health and for mental health. And we know that there's a very strong association between income and a whole range of health outcomes. Surprisingly, actually, the evidence for a causal relationship within the adult population in high-income countries is less established. So it's clearer for children and clearer in low and middle-income countries. So to try and interrogate this a bit in a bit more detail, we've been taking advantage of the very rich data that's available to try to estimate the effects using the observational data that are available. And we're starting by trying to understand the effect of poverty on mental health, as an example. So when we look at the whole range of quite rich covariates available, you can see that if you compare people who experience poverty to those who don't, they are quite different, those groups. So that's indicated in the blue there. However, by trying to incorporate inverse probability of treatment weights, so trying to predict who is likely to experience poverty and who isn't, and account for that in the analysis, we can try and make our groups much more comparable, which can be seen in the kind of orange color. And actually, we've been able to improve on this a little bit since I made the slide. So we're actually able to try to get closer to understanding the causal effects. And when we do that, we actually find that, yes, poverty is important for mental health, but at the individual level, for any individual, the effects are relatively small. But sadly, because poverty is so common in the UK at the moment, actually at a population level, it's still pretty important. So if we think about common mental health disorders, roughly 1/10 of them can be accounted for by poverty, with some difference between men and women. So it seems to matter more for men than for women. So as we think about next steps and moving beyond the acute phase of the pandemic, there are going to be direct and indirect harms that we need to think about longer term. Many of the indirect harms could well dwarf the more direct consequences of COVID infection, with the economic impacts and also the social policy responses being particularly important when we think about mental health and inequalities in mental health. While I've provided more examples from issues related to the working age, it's also important to note that actually for many young people and children, the disruption they've experienced will also have potentially quite long consequences for their health as well. There are, of course, other important challenges that we need to think about. So, for example, there's obviously the climate emergency, which is going to be a real public health priority and has been for some time, as well as issues about levelling up. And what I've tried to illustrate today is some of the real strengths that being able to use the Understanding Society data brings. So in particular, by having such a rich data set that's collected over time, that's longitudinal, that's allowed us to try to understand cause and effect relationships, both through analyses of longitudinal data using, I suppose, more causal epidemiology approaches, but also using what we might think of as natural experiment approaches, where we try to evaluate specific policy changes. The fact that the data have been collected and in such a responsive way and such a timely way during the pandemic has also allowed providing results to policymakers to really impact on policy and provide insights that wouldn't otherwise be possible. And the fact that the data are representative means they have real policy relevance as well. And lastly, Understanding Society is really unique in terms of its sample size, which allows an in-depth understanding of inequalities, including ethnic as well as socioeconomic inequalities, which is often not possible when we're looking at other data sets. So I'll stop there, but just wanted to acknowledge some important funders of our work. Thank you very much.